Here's a snapshot of our endocrine and diabetes staff. We serve about 2,700 patients with type 1 diabetes and about 275 with type 2. And today I'm going to talk to you about a qualitative study that we conducted to inform the implementation of a new diabetes tool in our clinic. I'm going to start with my takeaway message, and that is that the how is just as important as the what. So how you implement a new tool or a process in your clinic is just as important as the tool itself or the what. So the what that I'm talking about today is the TIDE dashboard. And the TIDE dashboard was developed by researchers at Stanford, and it stands for Timely Interventions for Diabetes Excellence. It's a population level tool that analyzes CGM data and provides a summary of the previous week's data in a visual output. And it identifies patients who are having a deterioration in glycemic control. So you can see in that top image there, that's one iteration of their view of the dashboard at Stanford. You can quickly see areas of red where some patients have been flagged for some areas such as time and range being too low or time spent too long in low or high blood sugars. Each row on that represents a different patient. The bottom is a snipped image of what it looks like in the Children's Mercy clinic. It's the same information, but it's just flagged. It has a little bit of visual differences. Now, Stanford University had a really successful rate with using this. They actually increased time and range by about 8.8% and reduced A1Cs by about 0.5%. So the evidence was really clear that this tool was fantastic for helping with glycemic control. So we at Children's Mercy really wanted to use this tool. But the big question was how? How are we going to implement this? You might see, remember in that last slide, we've got quite a large staff. And so we really wanted to gather some qualitative data from our clinic staff to make sure that we would be addressing any barriers that they perceive with trying a new tool in our space. Here's our key driver diagram just to show you how using the TIDE dashboard in our space is helping drive the needle to increasing the proportion of our patients meeting their A1C goal. So how we went about doing this, we started by creating a REDCap survey. It started with an introduction to the tool. It was actually a video because we wanted the staff to see exactly how the tool functioned. And since most didn't have experience with the tool, we showed them that through the video. And then we also presented them with some data on how we were performing as a clinic in relation to other clinics in the T1D exchange against some of the metrics. One question was showing how we were about in the middle of the pack as far as meeting our A1C goals. And most folks on the sliding scale said, yeah, I'm proud of that. That looks good, but there's definitely some room for improvement. So that really kind of set a purpose for looking at this new tool to use in our clinic space. We also included some questions framed on the COMD model, which looks at the capability, opportunity, and motivation for behavior change or using something new in our clinic space. And we also included the ORIC questions, which are organizational readiness to implement change. Go ahead and advance. We distributed this information to 56 clinicians, and we had 20 complete the survey. When looking at the role of respondents, most of them were physicians. We had quite a few nurses, dietitians, a fellow and social worker also complete this. Most of them were female. And looking at the tenure, most of the folks had been at Children's Mercy in their current role between 0 and 5 years. Some had longer tenures, as you can see. And so this survey basically showed us that there were 3 main areas of concern with implementing the TIDE dashboard in our space. One was around workflow, another around time, and the third was around training. So we came up with some test ideas or facilitators to really address those barriers that they perceived. And when talking about workflow, we've started some conversations about de-implementing some ineffective practices. So for example, we currently send a CDC-ES into every single standard of care visit. So we've talked about perhaps in the future we could test out not sending them in if a patient were meeting their goals. Also, to help with workflow, our data science team has built in a tracking tool right in the dashboard itself. So this just makes it a little bit easier to see at a quick glance of those who are needing this outreach. Who's been outreached to recently, what was the outcome of that communication without having to go into other management tools. In regards to time, everyone says, how on earth are we going to adopt something new? We all feel like we're stressed for time. So we just asked our clinic staff who would be willing. We had a little bit of funding, but we could offer some incentives for some clinic staff to take on a few extra hours and test out using the TIDE dashboard and then follow up with remote patient monitoring with those families. And then we also have talked about how just the concept of reviewing data in between standard of care time or standard of care visits is likely to free up some of the time in clinics later on because we've addressed some of those issues in between care. So the clinic appointment should be shorter. So we're going to look at that data as we go. We also heard from folks that did this survey, when they looked at that dashboard, they said, gosh, there's a lot of information there. I'm afraid this is going to take a lot of time for me to figure out, what I look at. And so we had our data science team add some visual cues in just so it speeds up the process for them reviewing data. And then as far as training, we heard some folks wanted recorded trainings that they could refer back to or do in their own time. Some preferred live sessions so they could ask questions. Some wanted written job aids. So we've done all of those. And while we haven't implemented this quite clinic-wide yet, we're well on our way. And those who have been a little bit hesitant about using the new tool are open to the idea of shadowing somebody who's more seasoned and experienced with the tool. So overall, we found that using a video introduction was really helpful in anchoring people and also anchoring to our existing goals. Conducting the survey with the staff using the COM-B framed questions and ORIC questions really helped us identify what barriers they perceive so we could address those as we're implementing them. And acting on the feedback that they gave us really helped gain some buy-in. So we heard, again, that looking at the dashboard initially, that first iteration had a lot of information. So those visual cues were helpful. We've also heard great suggestions around, I think it'd be great if a physician could see their population only. So our data science team has it on their pipeline to work on that iteration in the future. And we're always open to new suggestions from our staff. And that phased implementation has been really helpful, just starting with those self-identified champions rather than forcing it on everyone all at once. Is that my time? That has been really helpful. I think there's one more slide. Just a quick, I want to say thank you to Helmsley Charitable Trust for funding of our work and Stanford team as well as Mercy. Thank you for your attention. Are there any questions?
One.
Okay.
Sorry about the videos. Did you make the videos? And then also, did you know if they actually watched them?
Yes. Yes. Yeah, we just made that one video showing the TIDE dashboard tool, and it was embedded in the REDCap survey, so we could see that it was watched. Yeah.
Perfect. Thanks, Emily. So just to keep things moving here, and I'm sure all of our speakers will be happy to take questions at the end. We're now going to hear from Ashley Garrity from CS Mott Children's Hospital at the University of Michigan. Take it away, Ashley.
Hi, I am Ashley, and I am presenting on behalf of our team. Alex Wazlewski is one of our fellows, so he is leading this work, and I'm just here presenting on his behalf. But we are trying to work on a project to improve glycemic management by improving time and range and doing it through patient education. So just a little bit about our site. We are one of the original pilot sites from the collaborative. This is boiled down to by FTEs that are devoted to T1D patient care. We actually have 12 endocrinologists, but they don't all see diabetes. We have 3 fellows. We have dietitians and CDEs that are RNs. We have 2.0 social work split across 3 people, and we just filled our psychology position. We see about 1,300 type 1 patients, and we have about 150 patients that have other types of diabetes, type 2, MODY, CFRD. And we have upwards of 100 patients that are diagnosed each year at our site. So I know that I'm speaking to an audience that knows this, but the ADA recommends time and range of upwards of 70% for between 70 and 180. But importantly, as I noticed other people today were mentioning about severe hypoglycemia, we also want to keep that below 4%. So based on these guidelines, we really want to encourage our patients to meet these targets because it reduces their risk of complications. So one thing that we feel is really important is that time in range is an important metric because it's actionable in a way that people can see more regularly than every 3 or 4 months when they come to clinic. And as you guys are familiar, it doesn't, mask those things that A1C mask in terms of those, swings between feeling high and low, which we always talk about this with our families and say, it doesn't feel good when you're swinging back and forth. So not only is it better for you in terms of your long-term health, but it makes you feel better as well. So overall, our aim is to long-term improve time and range, but we're starting sort of small at the beginning step of, do our patients even know what time and range is and what the goals are? So the short-term aim was to increase point of care education that we're talking about these goals. So going from 0%, because we weren't doing this in any standardized way, to 95% over 12 months. So we have implemented a few PDSA cycles so far. The first one was that we just identified this gap in knowledge. So as a very first step, one of our providers talked about it with one panel of her clinic, and none of the patients really knew definitively what the range was or what the goals were. So we knew that this was an important project. We identified the gap. We also then in our second cycle create an educational handout. So it features those graphs that I just showed you as a way for visually our patients and families to see what the goals are, and then to see sort of how, an A1C can look very different, even if it's the same number. And we implemented that as a paper handout, and then it's also as a dot phrase that can be put into patient instructions in our EHR. And then we added some questions to our flow sheet. So at every visit, we have a flow sheet that our team members fill out. So the educators and the providers fill it in. So we added 3 questions as sort of education anticipatory guidance, along with our other education questions about, does the family know when to test for ketones, for example? So we added these 3 questions asking, does the patient or family know what the goal range is of 70 to 180? And then do they know that the goal is 70% or more in range? And then do they know that the hypoglycemia goal is 4% or less? So we initially tested this with our providers that are part of our QI team, and then we scaled it up to our entire division. And so we're measuring both whether they're talking about it at clinic, meaning did they fill out the questions, and then what was the knowledge? The choices on those questions are yes, they knew the answer, or no, and we provided education. So these are our preliminary results. We started in January identifying that initial gap. And then we piloted the interventions with the flow sheet questionnaires and the educational materials in February. But we did just start that with a small number of our team members, and then we scaled up. So as of June, you can see we got to over 70% that were asking the questions at the visit, which was really great. One thing though, and I encourage you guys to check out our poster because we provided an updated graph after I submitted these slides. But what we actually saw is that we got to over 70% and then we started to go down. But interestingly, we looked at the difference across the 3 individual questions, and it seems like our team was still reliably asking about the first one. Do they know what the range is? But they weren't asking about the goals. And so we've continued to do some reminders and education with our team about, do they know what those goals are and why weren't they asking them? Some of the, qualitative feedback we got was that it was, well, once they answered the first one, if they didn't know it, we just stopped. We just educated them on that one piece, and then we'll get to the rest later. So we encourage them to continue filling them out. So implementing something and standardizing it, especially at the point of care, since it's already in their workflow to be filling out the flow sheet, tucking some extra things in there seems to be pretty effective. And we have yet to see if it will have any impact on the proportion of our patients who are actually meeting that time and range goal of 70% or more. Our numbers haven't changed much since we started this, but again, we know that just educating them doesn't change their behavior or their outcomes. So this is just the first step in a long road of where we hope to go. I know some of you guys have heard us talk about our diabetes data and devices education program, or what we call D3, but that's all about understanding your data and then using the data for self-management. So understanding patterns and then knowing what to do with that information. So we see this as a way to then offer that class and get patients into that education pipeline where then they can take action and be empowered to make changes to improve their time and range. So this is ongoing, and hopefully we'll have more exciting outcomes to present down the road. Thanks. Yeah. Oh, that's a great question. And I should specify, I think it was in the slides, but so for these data, we were just showing among our patients that are using CGM. We can talk about time and range with our patients who use just meters, but it's not as informative when you only have like 3 points. We have about 85% of our patients on CGM, which I know is quite high. So this does capture a lot of our population.
And any other questions? And then I'm going to ask if you'll repeat the question when you hear it for our Zoom attendees.
Yes, sorry about that.
So I have one.
Yeah.
My question is, what do you feel that you need to see in your own clinic before you are ready to say we have something to share out?
That's a great question. I think we want to know with anything that we're doing that we're seeing the intended outcome. I think this is, very early stages and just, are we even talking about this with our families? I know time and range is something that I think everyone in this room is familiar with, but is a newer concept for our families, especially as, we've seen a lot of technology adoption over the last couple of years. Socializing the data piece in that metric, I think, is the first step. Are you asking specifically in terms of our education? So I think that we do want to share our educational materials, especially in terms of the D3 program that I mentioned. We are actually working on a publication right now, so hopefully we'll have some exciting things to share. Basically that curriculum, for those of you who haven't heard us present about it before, we talked to our team and basically said, what do you do when you're looking at a patient's data and how do you decide what to make changes on? And then we tried to distill that into the best practices that we then try to teach to our families. So we're hoping to have something that we can share widely soon.
All right, great talks to kick us off. So next we're going to hear from Dr. Sarah Corathers from Cincinnati Children's Hospital about the Connect T1D program.
Thank you, Mark. Pleasure to be here. Thank you. And I'll just share that I'm speaking on behalf of my co-investigators, who include Dr. Nana Jones, who gave a great talk this morning, Laura Smith and Pat Brady, as well as a large team, some of whom are also here. So thank you. So just wanted to begin with a parent perspective, which is really the inspiration for all of the work that I'll share today. Justin Masterson, who is well known to the T1D Exchange because he's been involved in some of these learning sessions in the past, is a parent in our center, and he created this visual that just sort of described clinic visits as the telephone poles, and all the time in between as sort of like all the other lived experience, the 99.9% of time. And this visual has really been very helpful at our entire team sort of reconsidering what diabetes care should be, and really breaking out of the mold of sort of a brick and mortar clinic visit and really thinking about sort of the connections all those times in between. So his quote is here. So again, the parents and the caregivers are kind of coming to us for support, but they have all this in between time. So we conceived of Connect T1D as sort of an opportunity to think about connections for families, connections to community, connections to clinic, but also all the time in between. So this work is part of a much broader recognition at our center about health equity. So those connections are really important for any family impacted by diabetes, but we know that the challenges of diabetes are felt disproportionately by people who are in more vulnerable social situations. And so on the left-hand side, you're looking at Hamilton County, which is where Cincinnati Children's lives. And those are poverty quintiles on a heat map, with the red being the lowest income levels. Reflecting some redlining history of our city. But so we're really interested as a center at looking at health equity across all conditions, not just diabetes, but across a number of areas of medicine. And then, of course, we're part of this incredible network and collaboration of 50 plus and growing diabetes centers in the United States, looking at outcomes. How do we work together to accelerate and improve them, but also apply an equity lens? And then Dr. Maz mentioned ISPAD, and then certainly SWEET is one of our international benchmarking collaborators. So we're trying to learn what's possible both in the United States health system, but also internationally. So this is just sort of framing to say we're thinking locally, but we're also trying to learn from our partners throughout. And so this is really what we set about to do. So with the generous RFP through the Helmsley Charitable Trust, there was a diabetes clinic innovation proposal, and they said sort of, what do you want to do to make diabetes care better? And we said, man, we've got some great ideas. And this is sort of a distillation of what they are. So we wanted to really accelerate and move forward on equitable access to diabetes technology, which is something I think that everyone recognizes as important. We wanted to better strengthen our community relationships. We wanted to have more robust and impactful communication between visits. And then our last aim, which I'll just touch on, is integration of diabetes devices into the medical record so that we can do cool things like the Tide dashboard and what they're doing at Children's Mercy in Stanford. So we launched with a design day session. So that's actually really nostalgic for me because we're also one of the original sites that was part of this collaborative. And so this entire thing that you're part of today started with a design session. And so we brought those lessons of participatory design to this work as well to engage patients, caregivers, and members of our diabetes center, both in an asynchronous way and then also an in-person. And this led us to our theory for change, which is a big, complicated key driver diagram. But again, our primary aim is focusing on a population of children with public insurance, Medicaid insurance in the state of Ohio called Healthline, and improving their glycemic outcomes. But we created through that design session about 50 different ideas that which we categorized into themes of access, technology, and psychosocial, created some process measures around those, and then developed drivers and interventions that we've been subsequently testing. Dr. Jones is leading the technology piece. Laura Smith is leading the psychosocial piece, and Pat Brady is helping to lead the access between visits pieces. So this is kind of a study of distributed leadership of the project. But this work reflects what Nana's been doing in listening to patients' voices and sort of bringing that into understanding what are the things that get in the way of technology adoption once we've overcome some of the logistical barriers of insurance and other things. And so we captured their voices and created a series of videos. And these are really, really terrific. And so we're using these as a way of kind of doing peer-based education at scale. Other examples of some of our interventions include training to community health workers specific to diabetes content knowledge. So our general pediatrics clinic has benefited from community health workers, but they've never had anybody have specific condition expertise. And so we're piloting this. And so those folks are doing some really terrific work. We've also taken the clinic to the community. So this is our clinic on wheels, where we literally get on a bus and go out into the world, into the wild world, and have clinics about an hour from our medical center. And then Marissa Town, who's here, I think, in the back of the room, is showing with one of our families, we say diabetes in the wild, doing some other social supports. So in terms of our outcomes, these are spark lines, just looking at our major A1C outcome as well as our process measures, which is just to say that things are all moving in the right direction. And importantly, we've been able to close some of our health equity gaps while still making improvements across the entire population. So I really want to take home the point that you can work on equity without sacrificing anything. Everybody can get better at the same time. The idea is to not disproportionately improve some of the population by neglecting to pay attention to the needs of others. With regard to the A1C outcomes for the Medicaid population, we've decreased by about 0.5 percentage point. So again, not to our target, but we're definitely making some progress. The shaded area on this graph is our baseline period. And then to the right shows the period of time where we've been working actively on the Connect T1D project. And these are our process measures. It's a lot for a short period of time to give a talk, but just to say we're tracking a lot of data. It's moving in the right direction. We're very encouraged that some of the interventions are really starting to bear fruit. And then so just lastly, some of the future directions, like everybody else, we're also interested in time and range. We're really interested in looking at automated insulin devices and how disproportionately that might be impacting outcomes in this population of children who are served on Medicaid insurance. Joyce Lee came in the room at exactly the right time. As our shout out, it's like we couldn't have planned it better. But our parent partner and health services researcher, Pat Brady, is really committed to this idea of access is not just third next available. It's not just consistent clinic visit, brick and mortar, but it's really, can you talk to someone when you need them? And how do we think about access in really more creative and different ways? And so we're looking at Joyce Lee's 6 habits, which I gave a trademark to, but came out of this collaborative to sort of think about what does it mean to be connected between visits. And then certainly the integrating CGM data into Epic and diabetes device data in general is our major lift for the upcoming year with our information services folks. The holiday lights thing up at the top there is just another example of community. We're going to be showing our CGM videos to families and inviting families to bring their families to the Cincinnati Zoo, which happens to be across the street from our medical center. Because one of the things we've heard from families a lot is that the impact of diabetes is not just on the child or the parent, but it's really on the whole family. So we're trying to think of ways of bringing folks together. So very multi-tiered interventions, but appreciate the support of Helms, the Charitable Trust, all of Cincinnati Children's, and Type 1 Diabetes Exchange for giving us a platform to share this with you. Thank you.
Questions? So I have I have a question for you. One of the I guess interests that this group will have is remote patient monitoring, and you sort of alluded to what's happening in between visits. And I just wonder if you can speak to what your institution is doing regarding remote patient monitoring, whether you've been looking at the billing codes for this, how you think about that through an equity lens, because we certainly don't want our families to suddenly see new charges that they haven't seen before, et cetera. So I've been struggling with this. I'm just curious about your thoughts.
Yeah, so remote patient monitoring is an intervention that we'll be doing in the near future. Our hospital has chosen to do a centralized model of remote patient monitoring, including all different types of conditions. So we're not going to do it individually as a diabetes center. We're going to be part of the organization. And they've chosen to not balance bill. So essentially, families will agree to participate in remote patient monitoring. A bill will be generated to their insurance, and then whatever revenue is generated, the hospital will take that back to the Center for Telehealth, which is sort of who's the institutional home for this endeavor. And they've chosen to not balance bill so that families won't receive a bill. And this is, I don't know how long that's going to last or how sustainable that is, but they felt like it was a really important innovation in healthcare for us to learn about and to pursue. And we didn't want there to be barriers in doing so.
Hopefully ROI coming in at the end of this, right? And yeah, sorry. With RPM based programs that, you're going to hopefully reduce ER visits, hospitalizations. So it will come back to the medical center eventually, hopefully.
Yeah. And to Shivani's point, I mean, I think the hospital's chosen to be selective in terms of starting with some of the highest risk populations. So NICU graduates, dialysis patients, heart transplant patients.
Yeah, thanks so much, Sarah. Round. All right. And so next we're going to hear from, I want you to help me out because I don't want to.
Jovan Milosavljevic.
Thank you. Thank you. That's my bad for not doing my homework beforehand. But we're going to hear about promoting CGM prescriptions in academic training centers. And Jovan is from Albert Einstein College of Medicine. So thank you.
All right. Thank you. So as we know, CGMs could be a transformative tool in diabetes management, and it's likely underutilized in trainee clinics, meaning residency and fellowship clinics. And this is especially in primary care. There's a unique opportunity to start these CGM interventions in trainee clinics where the provider practice habits are being developed. Over the last year, we have used QI methodology to increase CGM prescription rates in endocrinology trainee clinics. However, we wanted to expand this into primary internal medicine clinics. So our objectives were to examine baseline CGM prescription rates across endocrinology and primary care trainee clinics and look for factors that are associated with CGM prescriptions. We then plan and test these interventions to promote CGM prescriptions in trainee clinics using QI methodology. So for our baseline data analysis, it was done from January to March of 2023. We included adults older than 18 years of age that had a visit with adult endocrinology or primary care in residency or fellowship clinics in this study period. And we decided to include patients with multiple daily injection insulin use as being CGM eligible. Data was collected from EHR, and in terms of statistical analysis, our primary outcome was CGM prescription as a binary outcome, which we modeled via logistic regression. So this table shows our baseline characteristics. So in total, we have 244 patients, mean age of 58, with half of being male and half Hispanic, followed by non-Hispanic white. In terms of differences between endocrinology and primary care, patients seen by primary care only were older, more likely to be Spanish speaking, and more likely to have diagnosis of type 2 diabetes. These are our CGM prescription rates in endocrinology training clinics and primary care. And there were significant differences from endocrinology with 49% compared to primary care, where only 11% of CGM eligible patients actually received a CGM prescription. And when compared to non-trainee endocrinology clinics, which is 75%, which is for the non-trainee endocrine faculty clinics. In multivariable logistic regression analyses, age and male sex were not associated with CGM prescription. However, Hispanic, race, ethnicity, and being seen by primary care only were independently associated with lower odds of having CGM prescription, despite no differences in language preference. So CGM prescription rates overall were low in trainee clinics compared to Montefiore endocrinology clinics, which was expected in primary care, but unexpected in fellowship endocrinology training clinics. As we saw, CGM was less likely to be prescribed for patients of Hispanic race ethnicity. This was not associated with language preference. And efforts need to be ongoing in endocrinology training clinics. However, new focus needs to be primary care. And based on these data, we decided to create a QI project with a smart aim to increase CGM prescription rates among the diabetes patients in Montefiore internal medicine resident clinic by 10% by April of 2024. And this shows our key driver diagram with primary and secondary drivers. And most of our interventions are divided into two areas. One is to increase education of prescribers by understanding different types of CGM, having available, and then the second will be to streamline the prescription process and to have a logistical support by having an easy to follow CGM prescription workflow, prior authorization workflow, to have access for technology upload and download, and to have contact info for CGM reps. This shows our fishbone diagram and several problems that lead to decreased CGM prescriptions in primary care clinics are represented here by policies, product, equity, place, process, and people. And I'm just going to highlight a couple of them. In the policies and procedures, for example, from what when we talked to our primary care physicians, some of the confusion was, for example, variation among payer requirements and when CGM is a DME, when CGM is a pharmacy benefit. So primary care physicians did not know about these requirements. Then lack of access to CGM data. We spoke to some PCPs who even had their patients on CGM, but their patients kept keeping the log, physically log on a paper to bring their to their PCP for review. So they did not have access to CGM reports. And then in terms of process, of course, there are always competing priorities in PCP office. When you need somebody with a colonoscopy, health screening, mammography, CGM prescription might not be one of the top priorities. So this is the timeline that we proposed for our project, and we started this in July of this year with baseline data analysis, project planning, meeting with clinic team, prior authorization staff, and CDEs. And from October until December, we're doing education for providers, both about what CGM is and how to order it, but also interpretation education for providers. We created a prescribing workflow, and we're working with pharmacy and prior authorization staff. The next steps are from January. We're already involved in training our CDEs so when PCPs prescribe CGM, the patients can be seen by CDEs for device training if they're not able to do it themselves. And then for April, we're planning to track our prescription rates and see the results. I want to thank our QI team and the Philip Leaf Quality Improvement Program with QI coaches and the T1D training.
I'm just curious as to if you're gonna further break down how much clinician bias comes into play.
That is I mean, educational providers might be the first thing how to address these biases. And I mean, they should know whom to prescribe CGM, and if patient is on insulin, technically they should be eligible regardless of their control, diabetes control, or anything else. So, you know, educational providers might be the first step about addressing the biases.
To add to that question, you know, there've been some data that there are different ways in which providers express implicit bias. You know, sometimes it has to do with race and ethnicity, sometimes it has to do with socioeconomic status, and sometimes it has to do with their perception of the family's education levels, sophistication, intelligence, or organizational skills. And so I think it would be very interesting to think about like phenotyping the provider group and maybe creating a package for other centers to do the same. Other questions I heard.
I just want to say we've done a little bit of this work at Montreal already with our endocrinology provider. Some of the primary care providers are actually included with peds, general peds, and general internal medicine. And resoundingly, the perception that it was going to be hard to prescribe a CGM for a medicated patient was really like all of the logistics of getting that CGM for that patient. So the prior authorization, how is the patient going to get trained? Who is going to do the tech support for that patient if they could, you know, they have digital literacy issues or they have tech, phone issues. And so in endocrine, we really changed the structure of the clinical kind of pathways to enable people to actually prescribe CGM. And that already got rid of like what was perceived as bias, but it actually wasn't.
You really think that's the cause? Because
I don't
those
think-
things exist in every patient, obviously, right? So there's clearly a bias that is changing the numbers.
There is, but I think that you can fix a lot of the like perceived bias. I guess I would say the results of perceived bias can be improved by just making it easier to prescribe and easier to support patients.
Right, but that's
And then
not
you
the
can
answer.
No, you can also work on bias. So like part of the education, I know, you know, is bias training. Like we did this for our endocrinology providers. We actually did role playing CGM conversation, CGM introduction, talking to like difficult patients, whoever that means that exists. So hopefully in primary care.
One would hope also that, I don't know whether you've tried this or considered trying it, but audit and feedback can be a very powerful tool,
Yeah.
especially if it is public and transparent. And I think that if you share with your providers what their rates of prescription look like relative to their peers, they'll come to their own conclusions about it. So, great, thank you so much.
Thank you.
Yeah, nobody wants to be an outlier unless it's in the positive direction. So, okay, so now we're going to hear from Dr. Thomas from CS Mott at the University of Michigan about managing diabetic ketoacidosis in a unique way.
Thank you. So this was a project that was spearheaded by our fellow, who is now our faculty, and this was a collaborative effort between us, pediatric emergency department, and then the pediatric hospitalist team. So Ashley already told you a little bit about our hospital system, and so I'm just going to just dive into how we treat DKA. So DKA in our system is treated with an insulin drip and a two-bag system if you come to our emergency room with a bicarb less than 16. The individuals that are on an insulin drip are managed either in the emergency department or in the pediatric ICU. If a patient is considered going to be like pretty quick, a lot of times they stay in the emergency department because the pediatric ICU beds are then prioritized for patients who will need a longer time. So since our hospital has been extremely busy, patients have had to stay in the emergency department longer than we'd like. This would result in actually longer delays for starting education as well in our new onsets because the education can only happen on 12 West, which is our general floor bed. So our objective was to establish a moderate care unit on the general pediatrics floor to care for patients with mild to moderate DKA on an insulin drip with a two-bag fluids delivery method. Our hypothesis was that the shift in the care model would shorten length of stay in the hospital. But first we had to identify who was eligible. So we chose to include children in considered mild to moderate DKA, and we labeled them as a pH on VBG greater than or equal to 7.2 and a serum bicarb of greater than or equal to 13. We also only included children older than 5 years old, since we felt that they'd be most likely to eat once we took them off the insulin drip compared to children less than 5 years old. We used several QI methods, including creating a key diagram, mapping processes for patients and physicians, and developing care protocols, as well as designing educational materials for all care providers involved. So our aim was to reduce length of stay of patients admitted for mild to moderate DKA, and we focused on two outcomes, length of stay and the patient experience. We approached this project in many different ways. The first part was we looked at team education. We needed to make sure that anybody who had touched the patient knew how to take care of our patients. So we educated the hospice, and we'll tell you why in a second, fellow, resident education. We also spent a long time educating nurse education around DK and insulin drip because the nurses on the floor did not know how to take care of these patients. And then we, of course, had to update the resident education handbook. We also had to go through the pharmacy. Since every team has a different pharmacy team. And so we had to make sure that we had appropriate dextrose foods on the floor as well as hypoglycemia rescue medications. And we also needed to let the pharmacy know when we took the patients off the insulin drip and put them onto subcutaneous insulin. So we had to improve our documentation process since it was not as simple as them telling the pharmacist in the unit. We created a moderate care order set. We were on Epic, and we created a dashboard so we could track the patients. We also focused greatly on the patient-centered care. So in the emergency department and the ICU, they can pull the labs off the IV, but on our floor, they have to poke the children. And so we wanted to make sure that we made it as not painless as possible, but at least as easy as possible. And so what we decided is because we kept the pH and the bicarb so high, we thought they would only need 1 or 2 pokes. And so we changed our labs to every 3 hours to reduce the number of blood draws. And we also worked on trying to get patient and family education to be started earlier as long as the family was ready. We created multiple protocols and processes for moderate care, and we updated our clinical practice guidelines. And then we also emphasized a culture of safety. So once we started doing this, we realized that hypoglycemia was actually quite complicated for people who do not deal with diabetes very regularly. And so we worked on highlighting hypoglycemia management, and then also educating the teams on the complications of DKA. And like I said, we spent hours on hands-on training for nursing on management of insulin drip. We first started our workflow looking at the patients. So we wanted to make sure, first of all, if the patient was older than 5 years old and in DKA, that they could potentially have this option. So if the patient did not meet criteria, they could stay in the emergency department or they could go to the ICU. And once they met criteria, then they can come out to our floor. Once they got to the floor, they would be admitted to the pediatric endocrine team with a hospitalist consult if the patient was expected to be on the drip after 5 p.m. Our hospital mandated that an attending physician be in-house with a patient on an insulin drip. And since pediatric endocrinologists don't stay overnight, we needed to make sure we had someone capable. And so we had 2 pediatric hospital medicine physicians who were very comfortable with treating DKA due to their past history. And so they were our partners in this project. And so we would consult them if the patient was expected to be after 5 p.m. And if they came off the drip during the evening time, then they would revert to the pediatric endocrine team as the primary managers. And then again, we created a big red box. So that way we knew how to take care of hypoglycemia. So during this process, we treated about 25% of our patients through this protocol, and we reduced the length of stay by 30%. From about 76 hours to 51.1 hours. When you looked at the length of stay in each place, including the pediatric endocrine department, the ICU, and the inpatient length of stay, they all went down. So this was very exciting for us and, of course, the hospital. So in conclusion, mild to moderate DKA can be successfully cared for in a moderate care setting, and our initiative shortened length of stay for hospitalized patients who presented at DKA. Thank you.
The nurses that took care of the patients on the floor, the moderate care floor, did they have their patient to nurse ratio? Did it change if they had a patient on a drip? And what was that?
It went 2 to 1. It was initially, I think, 4 to 1 or more.
Might not be gotten to you, but in adults sometimes we do it. For mild DKA, has a sub-Q DKA protocol ever been considered as opposed to needing drips?
So the question was whether or not we could use a sub-Q protocol instead of using insulin drip. So for mild DKA. So we used to do that actually during my fellowship. And so that actually changed a couple of years ago when we created the clinical practice guideline that put everybody whose bicarb was less than 16 on a drip automatically. And we saw that the length of stay with that actually decreased it as well.
Do you have any data about patient experience and what that was like during this process? So if people were more comfortable on the ward as opposed to the emergency room, or if they were more nervous, if there was like sometimes nursing anxiety gets passed on to patient families. So how many
So the question was about patient experience. So we did not specifically query the patients. I will tell you from a nursing standpoint, there was anxiety, especially sometimes because the hospital was so full, they converted to moderate care status in the ED. And so again, they would have to sit in the ED until they met criteria to go to the general care status. And so what was happening is the patients in the ED, they continue to do labs the same way. And so we had to convince them, we're like, no, you have to move to every 3 hours. You can still pull off the IV. We're not going to force anybody to poke a kid. But I think that was the biggest issue. And I think, frankly, I don't think the families even knew that we were doing this, right? Because a lot of these were new onsets. And so they just continued on. I think they were happy not to sit in the ED for an extra day, just waiting for somebody to come start the education. Yes.
did any balancing measures in terms of any complications or downwards to the ICU because of what things happened?
So there was one kid just recently, actually outside of this data, who actually did go back to the ICU. And that was actually because the patient became hypernatremic. And they did not feel comfortable. The hospital team did not feel comfortable also managing them on the floor. But that patient actually got 3%. So there was obviously multiple factors in there too. In our CPG, it does say that if they have to have normal mental status, and so the patient was becoming a little somnolent, and so it was an appropriate transfer back. And in hindsight, like the patient probably should have never met moderate care status. But otherwise, there was no other bounce backs. Yes.
So we somewhat similar with COVID, except our floor does not commit syndromes no matter what. And so our Band-Aid is that if they meet the similar criteria in the ER, we give them Lantus instead of the floor with Q 3-hour insulin. I don't know if anybody else is saying similar or how do you get your floor to do an insulin trip?
So it's interesting, in Children's Mercy, we've actually done sort of the reverse of what you've done, which is we gave up our addiction service entirely to the consult service. All the DKAs are managed by our hospital service. We created a CPG. Everybody gets an independent consult, and we're able to do in-service training with all the nursing staff on one floor. So all the patients can visit one floor.
Our 12 West. Yeah. So we used to do sub-Q insulin, but then we switched to the CPG, which has them all going in insulin drip. During COVID, we actually did outpatient education. So we pushed patients. If they were not in DKA, we tried to get them home. And so we know we can do outpatient education, but again, I don't have staff to continue outpatient education.
So it's really a great set of talks today. So I think we've got about 8 minutes to transition to the next session. And I would just say for any of the speakers, if any of you have questions for the speakers in this session, find them after here. And, we heard a lot of information about CGM access and prescriptions, DKA care, population health management, et cetera. So good stuff today. Thank you.